The first is on early warning system modifications in patients with do not attempt CPR orders in a provincial New Zealand hospital. And Dale Keown from Nelson's going to present. Thanks, Dale.
Kia ora koutou. Thank you very much for the opportunity to speak here today. I'm Dale. I'm a junior doctor from Nelson Hospital. I'd just like to acknowledge the critical benefit of interweaving powerful stories that we've heard during today through conferences like this, which are hugely beneficial for junior clinicians like myself who are just starting off on their healthcare journey. So thank you to you guys. This afternoon I'd like to talk about something quite specific, some work that we've done in Nelson Hospital exploring early warning score modifications in a cohort of patients deemed not for CPR. It's been shown that the presence of a not for CPR form in patient notes can increase the chances of a misrepresentation that patients not for wider aspects of resuscitation. Patients with the label of not for CPR have been shown to be more likely to experience inappropriate withholding of a variety of investigations and treatments. And there's also evidence to suggest that even when matched for comorbidities and severity of disease, the in-hospital mortality of those patients with not for CPR forms versus not is actually higher. Now, you're all familiar with this chart, so I'm only going to touch on it very briefly. The early warning score system is a nationwide system, soon to be, designed to detect deterioration in ward patients, and each hospital has a slightly different escalation threshold. This is Nelson's, but our area of interest is the modification section in the bottom right, in which parameters can be modified for patients with chronically deranged physiology, for example, someone who has a chronic airways condition who's on home oxygen. Can also be used in a time-limited fashion for physiological derangement, which is expected to improve with current treatment. Now, we noticed that modifications to the early warning score seem to be relatively common in patients with not for CPR forms in our hospitals. So, given this is potentially a population already at risk of a higher threshold for escalation and the potential for a double risk if inappropriately modified, we thought we'd look into this a little bit further. Now, on the right is our previous, at the time of the work, this work was done not for CPR form, which is similar to several other centres. What we did is we conducted a retrospective chart review of 63 patients admitted from our emergency department to our general medical unit who had these not for CPR forms filled out on admission. We then reviewed electronic and paper notes, looked at the early warning scores, modifications that were made, and the outcomes for these patients. So first of all, it's acknowledged that patients with a not for CPR form are certainly at risk of dying. This is why the discussion has been had, why the form has been filled out in the first place. However, in our particular cohort, 3%, or 2 patients were at the time of admission for a best supportive care approach and were designated not for use scoring. And for the remainder, these charts summarise the outcome. The left one shows the proportion of patients that were discharged from hospital alive, 77% in all. The right hand shows what the discharge destination was for those that were discharged alive, with 82.8% discharged back to home or to rest home level care, which indicates, at least subjectively, a reasonable level of independent function. Now, overall, although not shown here, around about 85% of these patients were discharged back to the level of care that they were admitted from. And if we look 1 year post-discharge, around 60% were still alive at that stage. So this is not an end-of-life population per se that's having these forms filled out. In terms of modifications to the early warning score, around 70% of patients had a modification made at some point during their admission. And this is compared with a background rate of around about 20% if you look at all admissions to the medical unit at our hospital. Over half of these modifications were made at the time of admission, and these amendments were of particular interest to us as they have the potential to persist throughout the patient's stay. Now, in our particular cohort, the average early warning score value was 6.18 in the emergency department, which was reduced to on average 3.73. And bearing in mind that in Nelson, and I think it's similar to most other places, a review is triggered with an early warning score value of above 5. And on average, 2 parameters were adjusted per patient. Now, I'm now going to move on and look at those patients that were modified at admission in a wee bit more detail. Now, one of the most striking results that we found was that modifications made at admission, only 12% of these were time limited in any way. Now, this is a potential issue as the persistence of these modifications can result in a blunting of the early warning score to detect subsequent deterioration on the wards. Now, the other important element of a modification when made is the rationale, which puts the amendment in context. For something like a pneumonia, a high respiratory rate in the first 4 hours before antibiotics have had a chance to take effect is probably appropriate, but 4 days down the track, maybe less so. Overall, around about 30% of the modifications that we looked at had a reason documented. The horizontal axis of this graph is the parameter modified, and the vertical axis is overall the number of modifications that were made to each. And the dark green shows the proportion of modifications to each parameter which had a reason documented. Respiratory parameters tended to be the most commonly amended. Often these were oxygen parameters for COPD patients or airways disease patients. However, the rationale for respiratory rate modification was seldom completed, which is important if we think about the context of respiratory rate as being the most sensitive marker of decline potential. No modification that we found, or sorry, no rationale that we found was documented for any heart rate or blood pressure modifications. So we then asked, were those that were being modified on admission versus not a different cohort? And this table shows some of the characteristics between these two groups. Moving from the top down, those that were modified were similar in age, had a similar number of medications on admission, which is a very simple proxy for the complexities of comorbidity. And the length of stay in hospital was slightly longer, but not significantly different. Unsurprisingly, those that were modified presented to the emergency department with a greater physiological derangement in that they had a higher baseline early warning score value. However, they weren't more likely to die in hospital than those that weren't modified. And even when we looked again a year down the track, we didn't see much of a difference in 1 year survival. Now, these are examples of modifications that we came across that sort of illustrate the spectrum, I think, and it's always difficult to take these into account contextually, but they are example. All 3 of these patients were admitted from home. All had ceilings of treatment which included ICU management if required, and all were discharged back home after their lengths of stay. And I think it's difficult to see, especially with the second and third, how much of a physiological derangement would be required for an escalation to occur. So this is sort of a graphic representation of where we perceive the potential issue to be. It shows the first 5 days of a real patient admitted to the general medical unit with congestive heart failure and a fast heart rate, atrial fibrillation. The horizontal axis is time over 5 days. And the vertical axis is a representation, if you like, of physiology with the early warning score value 0 to 10 or above. The right-hand axis shows the threshold for house surgeon review as well as rapid response team call. So we can follow this patient's physiological journey from left to right over their first 5 days. The first red arrow is admission to the medical unit after a period in the emergency department, and it's here that our lines diverge, with the modified U's continuing in black and the unmodified in red. And the second arrow on day 3 represents a rapid response call to the ward for a deterioration in respiratory rate and oxygen saturation secondary to what was later found to be a developing pneumonia, which resulted in transfer to ICU for increased monitoring and I think eventually BiPAP. So you can see that despite the EWS increasing for a number of hours prior to this rapid response call, the amended score remained below the threshold for review until just prior to what was then a significant deterioration. So This patient improved and was discharged back home after a 12-day admission. Now, you're likely thinking this is not big data. I'm sure especially the intensivists among you are readying the fruit and throwing out. Certainly, we are a small centre. This is small numbers. We're a provincial centre. And to make matters worse, I've just finished with an anecdote. Some modifications that are made do represent baseline physiology and may prevent unnecessary reviews on the ward, which certainly can have an opportunity cost in a small hospital like ours, where we have 190 beds looked after by 2 RMOs overnight. We've not looked directly at harms, with the persistence of amendments a proxy for this only. We did try and look and see if there was evidence of these persisting amendments in patients who had had rapid response calls on the ward, but at that stage no data on this cohort was being collected. We're looking to change that at this stage. So in conclusion, we found that in a cohort of not for CPR patients who had high rates of discharge to home or rest homes, modifications of the early warning score were quite common, but time limitation and rationale for these were infrequently documented. Now, these patients may not have been for CPR, but there were a variety of other escalations that may have been appropriate, and we worry that persisting modifications could increase the threshold for these escalations, which is separate from the ceiling of care that they would be escalated to, in our opinion. Now, there are certainly protective factors which we've discussed today. There's nursing vigilance, ward rounds, family and whānau escalation and concerns, but these are all active interventions, and the early warning score system works so well because it's a passive prevention system. Now, since this work in Nelson, there have been some events which have led to more of a focus on modifications in our hospital, with increased education around amendments as a result of this. And with the help of Jen from the quality improvement team, who you've heard from, we've just started to collect NHIs of those patients who have had rapid response calls, which will hopefully give us an indication as to whether these amendments are a significant issue in our hospital. In addition, we've introduced a new tiered goals of treatment form to replace the sort of dichotomous not for CPR form, which I'll discuss in a wee minute. And we've just finished the second lot of data collection to follow up on this to see whether there are any of these interventions have changed the modification profile that we've got. So, as far as we're aware, there's very limited literature on EWS modifications in this cohort of not for CPR patients. We think this is an area that potentially deserves further scrutiny, and I'd be interested to hear your thoughts on that, particularly those of you from smaller centres as well, as to whether you've experienced anything similar or not. Thank you very much for your attention.